this specific event that we organized on behalf of the public mental health section, specifically to discuss the issues of and discuss new challenges in public mental health through eyes of young people, through voices and by observations of young people, and to address those challenges in nowadays times. So this is the workshop that was organized by the Public Mental Health section of European Public Health Association, and on behalf of Professor Jutta Lindert and Professor Johan Bilsen, the most warm welcome to all of you, and especially our presenters and young participants and experienced participants as well. This workshop is actually aiming to strengthen our networking and in public mental health field, and especially also to identify and discuss those new challenges in mental health, exchange our views and experiences. And my message to our young speakers today is that it's absolutely open, very friendly and supportive platform for you to share your views and your experiences, your research findings with us and discuss them in a wider audience. So before we start our workshop, collaborative workshop, I would like you to introduce to some organizational kind of framework. First of all, we would like you to ask and keep your microphones muted during the whole workshop, unless and cameras also turned off, just to keep the connection safe and vivid. And only the presenters are kindly asked to keep your mics and of course cameras turned on. And each presenter would have 12 minutes with a presentation, and afterwards we will have a couple of minutes of questions and answers session that would be chaired by Professor Johan Bilsen. All of you who have questions and comments and observations, you're welcome to put your questions into the chat section, and only those questions that are placed in the chat will be kind of put on the table for discussion. And with that, I would like already to welcome our first speaker and our first presenter, Severija Skabeikaitė. Severija is a medical student, second-year medical student from Vilnius University, Faculty of Medicine, and together with her colleagues and friends, they conducted a survey on sleeping habits of students and the relationship on the health and associations with health. So Severija, the most warm welcome to you, and you are kindly asked to share your screen and start the presentation. Thank you.
Okay, thank you. I'll start in a second. Can everybody see?
Yes.
Okay, so I'll start. As already mentioned, I'm going to be presenting a study on the topic of sleeping patterns of students and impact on health, the primary results. My name is Severija Skabeikaitė, and I did this study with Viltė Šapranaitė and Vidvilė Karnaitytė. We're all second-year medical students, and our supervisor was Maria Jakubauskienė. Here you can see the content of what I'm going to be talking about. And to begin with, a short introduction to this topic. You may already know that the recommended sleep time duration for adults, which includes young adults, is between 7 to 9 hours. Sleep disorders are associated with lower academic performance, and there are actually quite a few studies that researched the associations between sleep disorders and academic success, not so much health, but there still are some information on sleep relations with health, and it is found that shorter sleep, nightmares, and sleep medication use are all associated with a higher prevalence of suicidal behavior in students. On top of that, sleep issues and psychiatric disorders commonly coexist and can influence each other. More than 60% of university students report poor sleep quality, and shorter sleep duration is also related to non-psychiatric illnesses such as type 2 diabetes, obesity, and cardiovascular disease, among many others. So as you can see, it's quite a prevalent and important problem among students and in general in the population. So the aim of our study was to evaluate students' sleep patterns and their associations with physical and mental health. For that, we chose a cross-sectional study, and the data was gathered in the following times twice, for the first time in October and November in 2020, and it was continued in February and March for the second time in 2021. We had an anonymous e-based survey for data collection, and we made our own sleep and health questionnaire, which consisted of 3 parts. The first part was about demography, questions such as gender, age, degree of study. The second part consisted of questions on sleep patterns and duration and quality. And the third part, questions on physical and mental health. I would like to point out here that the questions were not in any way directly related to COVID-19 and the pandemic. But as you can see by the timestamps when the study was conducted, we can only assume that the answers could have been influenced by the pandemic. And convenient sampling technique was applied, and the sample size is 377 respondents. And descriptive statistic methods were used for data analysis. Frequency was calculated, relative risk, 95% confidence intervals, chi-square test, and significance level was 0.05. Now on to results. Firstly, a little bit about the demographics. As I've already mentioned, 377 respondents. The majority of those were women who were under the age of 25, and they were undergraduates. As you can see, the others were quite significantly less of other groups of people. Now on to sleep duration. We asked questions on sleep duration on weekdays, weekends, and during exam session. So on weekdays, the majority of students answered that they sleep about 7 hours. And the part that interested us the most was right here, about a little bit over a fourth of all of the respondents said that they sleep 6 hours and less, meaning that they sleep less than what is recommended. And we found that that was related to increased risk of fatigue. The risk was increased by 1.1 times, and the difference was statistically significant. During weekends, there is quite a big difference, and the students who said that they sleep under the recommended amount made up a very small amount of all the respondents, whilst the majority said that they sleep from 8 to 9 hours. And we found that even if students said that they sleep 7 hours and less during weekends, it didn't have any associations with worse health, be it mental or physical, and the difference wasn't statistically significant. And during examination session, we saw a big shift on the results because almost half of all of our respondents claimed that they sleep 6 hours and less during the exam session. And that was associated with an increased risk of bad mood, fatigue, and subjective health evaluations, meaning that it was more likely that students evaluated their own health as worse. Talking about sleep quality among students, only a fourth claimed that they use non-medical measures for faster and better quality sleep. However, the majority said that they experienced insomnia, and even more of the respondents claimed that they experienced sleepiness during the day. From that, we continued the analysis, and we found that sleepiness was more frequent if the individual experienced daily stress, and the feeling of sleepiness was also related to general fatigue at least once a week. Insomnia was related to chronic illness, and respondents experiencing insomnia more often had an anxiety disorder. It also increased the risk of bad mood, and the risk for depressiveness was increased by 4.2 times if a student claimed that he had insomnia. Use of non-medical measures for sleep was related to experiencing depression, and respondents using medical measures for sleep more often had low sleep quality. And now talking about subjective evaluations on sleep and self-perceived health, keeping in mind that our respondents were mostly under the age of 25, only a little bit over half claimed that their health is good or very good, meaning that they rated their health from 8 to 10 points. And quite a few rated their health as average, so between 4 to 7 points. And talking about their satisfaction with sleep quality, only a fourth was satisfied with their sleep, and the majority claimed that their sleep was only mediocre. Those students who were unsatisfied with their sleep quality more often experienced stress, and we found that the stress was also more intense. Respondents who were satisfied with their sleep quality experienced bad mood less often, and respondents who were satisfied with their sleep quality more often described their health as good or very good. So from this, we drew conclusions that half of all of our respondents slept 6 hours or less during the exam session, which is under the recommended amount, whereas on weekdays and weekends, most students usually slept 7 and 9 hours respectively. Shorter sleep duration during exam session was related with a higher prevalence of bad mood, fatigue, and lower subjective health assessment. So we can kind of make a conclusion that a typically bigger workload during exam season negatively impacts both sleep, and because it impacts sleep negatively, it also negatively impacts day-to-day life quality of students. Sleepiness during the day and insomnia at night was experienced by a large majority of students, and it was also associated with a negative effect on physical and mental health. Usage of non-medical measures for sleep was rare, however, it was related to lower sleep satisfaction. And even though most respondents were young adults, only half of them assessed their health as good or very good, and most described their sleep as only mediocre. So to end this, I can only encourage further studies on this topic, on students' sleep patterns and impact both on mental and physical health, and encourage discussion on what to do to improve these things. And that would be all for me today.
Thank you very much, Severia, for your very time-saving and very constructive presentation. And thank you also, you and your team, for your efforts that you put to conduct the survey, and also efforts to analyze the results and primary results that you presented today. I suppose we don't have a pause now, and we can move to the second presentation. And then the questions are more than welcome, and any kind of reflections you're very welcome to share in our chat. And thus, I would like to continue and invite our second presenter and second group of researchers. I would like to present Jacob Lindemann and Paul Kleya, who are also students of Vilnius University Faculty of Medicine. They are both second-year medical students, and Jacob and Paul conducted also a study on mental health among university students during the COVID pandemic, and they would like to share their findings on student mental health, their coping abilities, stress, and other items. So Jacob, the floor is yours.
Yeah, thank you, Professor Jakubowski, for that kind words. And hello, everyone. Thank you for the possibility to present here today. My colleague Paul and I, we're both second-year medical students. And last year we were conducting our public health project, and we were asking ourselves, how is the COVID-19 pandemic causing impact on us students? And is it measurable, and does it come down to changes in stress reception and altered coping mechanisms? And during this project, we wanted to analyze that. Yeah, so as I think all of us remember, the year 2020 began with the outbreak of COVID-19. In the middle of the semester, we were all faced with enormous changes. The life and habits of all of us changed dramatically, and we were all facing pandemic control measures, mandatory wearing of masks, strict lockdowns, and so on. Restricted travel, which is pretty bad for international students, as you can probably imagine. And yeah, it affected all population groups, but especially us as young people and us students. We faced rescheduling of events in general, poor availability of lectures, of seminars, in general, digitalization issues. And we wanted to see how does that affect us? And therefore, we came up with the aim to determine the changes in stress perception and resilient coping abilities amongst students all over Europe during COVID-19 pandemic exposure. In order to assess that, we conducted a prevalence study, which was performed by using an anonymous online survey. And this survey was conducted among 17 European countries. We applied convenient cluster sampling, and applied those to our participants. The only principal inclusion criterion was that the duration of study was at least two semesters, because we wanted the people to have experienced studies before COVID and now during COVID. In order to assess our criteria, we used the Brief Resilience Coping Scale by Sinclair and Walston and the Perception of Stress Scale 10, it's important, and conducted our survey in a specific structure. As you can see here, it's a little complicated. That's why I made this scheme. In the introduction, we gave some brief information on why we are conducting the study, and but not giving too many information to bias our results. Then we were asking for some socio-demographic information, such as gender, age, place of studying, and where the people came from, and which subject they were studying. And then we came to the retrospective part, where we were asking, first of all, for the coping. Well, we assessed the coping category, and then the perceived stress, and then changing with a little break in between, telling the people to now focus on the present situation and assess the same information again. In the ending, we just said thank you and have a good time. Yeah. Then afterwards, we performed statistical analysis by using Excel and PSS. And the level of statistical significance for us was alpha 0.05. The differences were considered statistically significant with P lower than 0.05. And now let's look what we found. First of all, here we see our age distribution. I'm sorry for this ugly numbers that was automatically calculated, and I couldn't change it. I tried my very best. So as you can see, our youngest participants were just 18 years of age. Our oldest were 33. This gave us, as you can see, the curve of participants. This gave us a mean of 20.69 years of age, with the most participants obviously in the 20 and 21 group, but with the median of 20. Yes, and the standard deviation was 1.979. For the gender distribution, we had 95 males and 208 females answering our survey. 2 people answered diverse, and 2 people preferred not to tell their gender. Considering the country distribution, here you can see we colored those countries where we received answers from, with the largest amount of answers from Germany with 141 answers, Lithuania with 102, the United Kingdom with 13, and the Netherlands with 12. Yes, now I prepared some crazy scheme for you. Here we want to show you the number, or the variety of fields of study, just to show you how many different subjects we were able to show in our study. The greatest participants were medicine and health students with 30%, social sciences with 18.9%, technological sciences with 10.7%, and natural sciences with 7.2%. Now, talking about the stress perception evaluation, we did analysis on the stress perception before and during, as I already said, and that revealed that before the onset of SARS-CoV-2 pandemic, 21.8% of students were experiencing low stress levels, 74% of students were experiencing moderate stress levels, and 3.6% were experiencing high stress levels. In comparison, now during the pandemic, only 12.7% of students were on the low stress category, 64.8% were in the moderate category, but 22.5% were in the high stress category, which is an enormous change. Further on, we did the coping ability analysis, and that revealed that before the onset of SARS-CoV-2 pandemic, 31.3% of the respondents were in the low resilient category, 57.7% in the medium category, and 11% were assessed to be in the high resilient category. In contrast, now in the analysis of coping abilities during the pandemic, this revealed a generalized shift in the resilience pattern. During the pandemic, 38.4% were considered low resilient copers, 49% were in the medium category, and just 12.4% were high resilient. In our case, the prevalence of anxiety and depression, we also evaluated some questions on symptoms which people may or may not have experienced. The prevalence of anxiety, depression, and stress symptoms has increased, and which is actually statistically significant. However, the risk of decreasing coping abilities was not statistically significant. So from all those numbers now, which were quick and many, what can we conclude from that? Well, the COVID-19 pandemic had an adverse impact on the resilience and stress perception among university students in Europe. Low and medium level stress perception groups reduced in number, and the high stress perception group increased by 5 times, which is crazy. The resilience shifted in 2 directions, actually. Students who expressed high resilience before showed an increase in resilience during the pandemic, while students with low resilience capabilities were barely able to improve their resilience skills and instead rather decreased their coping capabilities. The medium resilience group decreased as students either increased their resilience capabilities with N4 students or 1.3%, or decreased in their resilience capabilities with 7.2%. For the future now, as I'm coming to the end, we are planning to perform further statistical evaluation to compare differences between, for example, genders, or to assess specific fields of study where stress or increased more than it did in others, or also compare countries where maybe some different changes had adverse or smaller effect. Yes, we can now at the end only stress to be patient with each other, to have an eye on that dramatic changes, and stay strong. Thank you very much for your attention.
Thank you very much, Jacob, for your very interesting presentation and results. And I would like to encourage all the participants to give your reflections, thumbs up for the first presenters. And I pass the word to Johan.
Yeah.
Already. Yeah.
Thank you very much, Maria. Well, until now I don't see any question in the chat, or am I wrong? I cannot find the question until now. But in the meantime, perhaps I can ask already a question myself. So if there are other questions, please write it down in the chat. Questions about both these studies. But one question perhaps that I have already is about the first presentation. It was a little bit surprising for me that you say that exams are related to bad mood, fatigue, and sleeping disorders during examinations are related to bad mood, fatigue, and diminished subjective health. But I would suspect also that there would be a relation with anxiety or with stress or something, but that's not the case, or did I see it wrong?
No, I imagine that the stress and the anxiety disorders, or maybe not anxiety disorders, but the stress that the students feel during exam season could potentially be a lot bigger than it is on a day-to-day basis, and that increases and affects the sleep that students have during the exam season, and that it's sort of a never-ending circle where it increases the bad mood and the fatigue, and it's never ending. Then the stress increases, and so on and so on. At least that's how I would choose to explain these results.
Okay, thank you. Are there other questions from someone? You can also use the mic.
Maybe I can use an opportunity to ask you, Severia, a question, and also both to Jacob research group. What was the most interesting and unexpected results for you out of your research that you've done, and what would be your recommendations for young people out of your study the surveys that you've conducted? Thank you.
For me personally, probably the most, I probably didn't expect that the changes between weekdays and the change and the shift that was there for fatigue and bad mood and other mental issues that are experienced during exam season, that it would increase so much. And probably it's a big discussion that can be about what can be done to improve these things. And I imagine stress, I'm not sure how to say, relieving techniques such as, I don't know, meditation could probably help reduce stress, and also optimizing what students need to study, because sometimes the information is excessive, and that probably has a toll on students.
I have also another question from the chat. It's for the second group. The question is from Osden Gokdemir, asking what could be the root reason for not to be resilient while the students reported as they were resilient before COVID?
Yeah, I'll try to answer that. I'm not too sure if I understand the question correctly. So you think you were asking what is the reason why people were not resilient before and are more resilient now?
Or the other way around, not to be resilient while the students reported as they were resilient before COVID.
So that the resilience reduced?
Yes.
Okay, so I think that could be explained because the stress levels or the fields of stress became more diverse. Before we had stress because, I don't know, we had a lot of exams or something, but all of the rest of the life was more or less or had reduced levels of stress. But now common concepts of stress relief are not possible anymore because we are not able to perform our hobbies anymore or do music, see friends, whatever. Yeah, especially the reduced social life is a big reason. That's why resilience reduced from before COVID to now during COVID. Yeah, that are the reasons we would say.
Thank you. Another question. Someone would like to know, Anna Andrun, whether there are any mental health courses or offerings for the students at Vilnius University regarding resilience, time management, health literacy, and so on.
I think I should answer this with Professor Jakubowski together, as I can only tell it from the medical perspective. I can say that I feel very, very supported, either on a intellectual level, like if we want to do research in that field, but also if we feel stress ourselves, as there are plenty of offerings from the university has an own psychological council where every student can apply to and ask for help, which is really good, especially during COVID times. And you can go there and have, like, I don't know, 5 free meetings or something. And if there's still a need, okay, then you have to see how to get together. But yeah, I think, well, we always experience great help, but I think Professor Jakubowski can say more about that.
Yes, thank you, Jacob. I also can add that at Vilnius University Faculty of Medicine, we started quite early looking at public mental health issues. And I think in 2002, we started a public mental health course for medical students. Now we have one for master students. And a part of that, we have a joint initiative together with Jutta Lindert and Johan Bilsen. We already, for the 4th time, I think, we organized an international summer school on public mental health, which has been recently stopped by the COVID pandemic. And so we have local at the university, local courses, but a part of that in the European Public Health Association and Public Mental Health section, we also have an initiative, this summer school, summer course. And hopefully we will be able to refresh it when we are all will be more socially free to move and travel. Thank you.
Okay, thank you very much. I think we have to move on, taking account of the time. The 2 next presentations will be presentations from first-year medicine students, Faculty of Medicine and Pharmacology of the Vrije Universiteit Brussel. And the first group, I think there are more than 1 people who will present, more than 1 person who will present. The first group will talk about the relation between online learning and exam stress. And the second group about opinions of young adults about online mental health consultations. So I will give the floor to the first group. I don't know who will take the word. I think it's Chloe or, yeah, we will see. Okay.
Yes. So, hello everybody. We are students from the Vrije Universiteit Brussel, and we are going to present you our research about the relationship between online learning and exam stress. This is an overview of the topics we will discuss during this presentation. We will start with an introduction, then we will explain our research question, followed by the method, results and discussion, and eventually our conclusion. COVID-19 was first found in Wuhan in China at the end of 2019. COVID-19 is a highly contagious infectious disease that causes serious acute respiratory problems. The virus spread very quickly around the world, and the epidemic was quickly seen as a pandemic. This global crisis still has a major impact to this day. This impact is due, among other things, to changes in the psychological well-being of the population. Because of the COVID-19 crisis, the education system had to be adjusted, namely by switching to online teaching. This was introduced to reduce further spread of COVID-19 among the population. As a result, students had less social contact and some had to take over household tasks. According to a study at the ULB, the French-speaking University of Brussels, this resulted in less time for the study in 93% of the students and also for an increase in the stress experience. According to several studies, switching to online classes would cause more stress among students of higher education. This is why we came to the following research question. What is the relationship between the switch to online learning and the amount of exam stress for students in their third year of higher education at the Faculty Medicine and Pharmacy of the Vrije Universiteit Brussel during the exam period of January 2021 compared to January 2020?
So now I'm going to discuss the method. Our type of study was a retrospective cross-sectional study, which allowed us to compare two different exam periods, the ones from January 2020 and January 2021. Our population included students in their third year of higher education from the Faculty of Medicine and Pharmacy of the Vrije Universiteit Brussel. We have opted for the Bachelor Studies Medicine, Biomedical Sciences and Pharmaceutical Sciences. These are approximately 150 students. Then as a research tool, we used a questionnaire based on the DAS-21 scale about depression, anxiety, and stress, but we decided to eliminate the questions about depression because these seemed a little irrelevant to us for our research. The answers were ranged from 0 to 3, with 0 meaning did not apply to me at all, and 3 meaning applied to me very much or most of the time. And then we processed our data with SPSS Statistics version 27. So now a little more explanation about the calculation. To calculate the scores, we took the sum of the questions about stress and anxiety from the students, and we multiplied this sum by 2 to get a score out of 42. And depending to the score, you belong to a certain gradation in anxiety or stress. And table 1 shows the cutoff values of the different gradations in stress and anxiety. And then to collect the data, we used the online platform Qualtrics. The survey was sent to the secretary of the faculty, the student ambassadors, and the student associations. Almost no personal data was requested to keep the anonymity as high as possible for our research. And for this research, we also got the approval from the Ethical Commission of the UZ from Brussels.
So now I'm going to discuss the results. In total, we received 77 fully filled in responses, which makes a response grade of 51%. And as we can see in table 2, the majority of the respondents were women, medicine students, and the students studied at home during the exam periods of 2020 and 2021. We first did a paired t-test for the whole population to see if the average scores of 2020 for anxiety and stress weren't the same for 2021 or not. But as we can see in figure 1 with the error bars, we see that the score of 2020 is less than the one of 2021 for anxiety and stress with the p-value that is given here. Then we put every answer in every respondent to a category using the cutoff values shown in table 1 of this presentation. And then we did the McNamara-Bowker test. For anxiety, we see a significant difference with a p-value of 1.6%, which means that there has been a shift from lower to higher categories. We already had 23 people who were extremely severe for anxiety in 2020, but that has been increased to 43 people in 2021, while all the lower categories have been decreased. And for stress, we see that there has been no significant difference. We also wanted to see if there were differences between the subgroups gender, degree, program, and location. For this, we used the unpaired t-test and the one-way ANOVA. And here we use the difference score, which is the score of 2021 for anxiety or stress minus the score of 2020. And as we can see in table 3, excuse me, all p-values are higher than 5%. So we can say that the average difference scores are equal for each subgroup. If we have to give an answer to our research question, we can say that the amount of anxiety and stress has increased after the switch to online learning. Especially for anxiety, we see that there is a significant decrease from the lower categories and a significant increase for the highest category, extremely severe. And we found that there was no significant difference between the subgroups.
Now I'm going to talk about the reflection. The strength in our research was that we had a high response from the students, namely 51%. We also had certain limitations that we had to deal with during our research. The first thing we did was get to the very broad subject of mental health. We have taken exam stress and anxiety out of this group and looked at it in more detail. Our questionnaire, the DASS-21 scale, on which we supported, also had a part depression. Here we have chosen to leave this away as we did not test depression in our research, and otherwise it would become too broad. A possible follow-up study would be able to take on this subject and focus more on it. Another limitation we encountered was that online response behavior is lower than that of offline surveys. Online surveys will be more easily ignored and simply abandoned in the middle of the survey. An online survey could also cause a possible selection bias. For a possible follow-up study, we could look at the influence of the switch to on-campus lessons or some sort of hybrid lesson schedule on exam stress among students, and this may include depression. This was the end of our presentation, and we would like to thank you for your attention.
Okay, thank you very much, Maxime, Chloe, and Tessa. I will now immediately go to the next group, which is about the opinions of young adults about online mental health consultations.
Welcome everyone to our presentation. Today our group will talk about our research concerning the opinions and experiences of young adults concerning online psychological consultations. Our group exists of students from the Vrije Universiteit Brussel. Here you see a short summary of our presentation. We will start with an introduction and a research question, then we will continue to the method and results, and we will finish with a discussion and a critical reflection. As we all know, the coronavirus pandemic started already more than a year ago. One way to slow down the spreading of this virus was to avoid as much physical contact as possible, but the average human has an incredible need for social contact. Even though this was still partly possible with social media, it still isn't really the same as physical face-to-face interactions. This caused an increase in psychological issues, but due to the restrictions, the traditionally best way to handle these problems, namely psychological consultations, also changed. They changed from psychological consultations to physical consultations to online consultations. We were curious to find out about the opinion of the general population concerning online consultations in a, dare I say, crucial time for psychological aid. What caught our attention was the extreme lack of articles concerning the opinion of the general population. There were several about the opinion of psychologists, but not the patients. So that's why this research focuses on the opinion of the patients as well as people who have no experience with psychological consultations at all. Thus, we came to the research question: what are the opinions and experiences of young adults aged 18 to 35 about online psychological consultations?
To find an answer to our research question, we carried out a cross-sectional study. An online survey was posted on social media, such as Facebook and Reddit, in 3 languages. An announcement encouraged adults between the ages of 18 and 35 to participate in the study. To ensure the privacy of the participants, we made sure that the IP addresses were not traced. The identity of the respondents cannot be traced with the personal data received. We emphasize that the study is completely anonymous. The survey was drawn up on Qualtrics and consisted of 3 parts. First, the participants were asked for background information such as age, gender, student and work status, etc. In the next part, the opinions and experiences of the participants were assessed in 2 parts. Statements were drawn up and participants were able to tick their findings on a Likert scale. The first part questioned the practical aspects of online psychological consultations, for instance, questions about price, time, and so on. The second part focuses on the qualitative aspects. These statements are about body language, privacy, etc. Finally, the participants were asked about their preference between online and physical consultations. 221 participants took part in the survey, the majority of whom were between 18 and 23 years old. The majority is students and of the female gender. About a third has already received psychological help. Striking answers to the question regarding the practical aspect of online psychological assistance are that about half of the respondents think that online consultation saves time, that the step to physical consultation is greater than that to online, and that online consultations are cheaper. About the qualitative part, the majority thinks that body language is important and that it does not come well across through online conversations. 8 out of 10 find physical consultations more personal. The majority thinks that technical failures are common. About half think that facial expressions are difficult to read and that entering into a dialogue with the care provider is not as easy in online consultations as in physical consultations. These remarkable values are also the values that were analyzed. When conducting analysis, we see that there are several connections between proposition 3. The step to online assistance is smaller than the step to physical assistance. 18 to 23 years old agree more compared to 24 to 35 years old. Respondents who only received psychological help also agree more with this statement than respondents that received both online and physical help. Students and workers also agree more with this statement. In Table 5, you can also see some connections between the statement and characteristics of respondents. Here we see, for example, that there is a connection between the characteristic already received psychological help and proposition 16. Entering into dialogue goes just as easily online as physically. Respondents who receive both agree more than the other respondents. Finally, we looked for a potential connection between preferences of the respondents and the statements. About 90% of the respondents prefer physical consultations to online consultations. There are connections between statements 1, 15, and 16. The respondents that prefer online consultations agree more than the other respondents.
On to the discussion. The results on the practical side of psychological counseling are rather positive. Approximately 50% of the respondents think that online counseling saves time and that taking the step to physical consultations is greater than the step to online consultations. They also think that online consultations are cheaper. We see that the results on the qualitative side of psychological counseling are rather negative. 9 to 10 of the respondents consider body language important in psychological consults, and about 75% thinks that it doesn't come across well in online conversations. Furthermore, about 80% thinks that physical consults are more personal. It looks like respondents without any experience with online conversations are more critical against this form of assistance. They indicate that they would prefer to receive physical help and that there might be some prejudices. Similar studies show similar results. So we can conclude that the practical benefits of online conversations do not seem to outweigh the possible disadvantages that are tough to be seen. Almost 90% of the respondents indicate that they prefer physical consultations over online consultations. This brings us to the reflection. The strength of this research is that it's currently one of the few studies from the point of view of the help seekers. Most of the similar studies were based on the clinic's point of view and their experience. There are also some limitations to this study. there may be a selection or a response bias. Participants were reached through a post on social media on a voluntary basis. Everyone who responded is part of the study, which can lead to a gender bias, as we can see in the predominance of female respondents. There was also a very limited number of respondents who had experience with online consultations. The study offers the possibility to optimize online psychological assistance by analyzing the experiences and findings of the respondents. Finally, the answers were not further elaborated. The reason why a respondent chose a particular answer could be more cleared with qualitative research, such as an interview. So this concludes our presentation, and we would like to thank you for your attention.
Okay, thank you. I didn't find my video, but now it comes. Okay, thank you very much, Pieter-Jan, Kenza, and Elena. I am looking to the chat and to the questions and answers, and I see one question from Anna Andrun, and she asked, she said, "Thank you for your wonderful research to the first presentation. I would like to know, how did you differentiate between stress and anxiety, and regarding the mental health standing of the respondents? Were they absolutely depression-free?" It's a question of Anna Andrun. So how did you differentiate between stress and anxiety? The first group, someone from the first group.
If it's okay, I will want to give the answer. So we used the DASS scale, and the scale has 21 questions, 7 about anxiety, 7 about stress, and 7 questions about depression. But the 7 questions about depression, they seemed not interesting for our investigation or our research. So we decided to eliminate that. So we did the tests for stress with the 7 questions about stress, and for anxiety with the questions about anxiety. Are they depression-free? I think not so, but that's not what we have investigated. Maybe for follow-up researches, we can have a look to the depression, and then we have a more global image of the mental health for the students.
Okay, thank you. Are there other questions? If not, I can, in the meantime, ask another question to group 2. From the results that you got from your research, what is your opinion now about online mental health care or mental health consultations? Do you think it's often done, not often? Do you think it's something which can be organized more often in the future, also when there is no pandemic? Or what is your opinion about your findings?
If it's okay, I'll answer this question. Well, if we look at the practical, if we look at online consultations out of a practical point of view, we see that there are a lot of pros. But when we look at the qualitative point of view, we see that a huge amount of people think there are a lot of cons. Before we think about implementing online consultations, even after the pandemic, we have to really look at how to work around those cons, work around those problems, like, for example, the body language that is perceived as not coming through correctly through to online consultations.
Mm-hmm. Yeah. So you think it's more a question of practical issues. If they can be solved, then it will be done more also after the COVID, you think?
Well, I also want to add that about, I think it was 7% of the participants also took online consultations, and they had positive responses. So I think that it should be, you should try it if you are considering it, because yeah, our survey wasn't really representative in that aspect. but they have a lot of pros. So I think you should definitely try it if you are considering it.
Okay, people with experience, which have experienced already, are more positive towards it. Yeah.
Yeah.
Okay, are there other questions? Until now, I don't see any in the chat. If not, okay, if not, then we will move on with the presentations. Thank you very much, all the presenters of the previous presentations. The next presentations are coming from the second year of social work students, if I'm well informed, from the University of Applied Sciences of the Emden University in Germany. And I think the first presentation is about COVID and mental health by Daniel Benke, if I'm right.
Thank you very much. And so I start. Our presentation focuses on mental health during the COVID-19 pandemic. And at first, I will talk about factors influencing mental health with a focus on the pandemic-specific factors. Our second topic is the special situation of the emerging adults. And at last, we will give some recommendations on an individual level how to face the situation. The pandemic affected the non-modifiable factors on influencing mental health. And on a biological level, coronaviruses are suspected of causing neuropsychiatric disease. And elderly and younger people, as well as women, are more at risk of developing mental health issues. Members of ethnic minorities are also at risk, especially less well-integrated groups and people who don't have access to information in their native language. Moreover, social and geographical isolation is also associated with an increase in intimate partner violence. Critical life events also have a major impact on mental health. And pandemics as well as epidemics are associated with higher prevalence rates of mental disease. An infection with COVID-19 and the loss of relatives are also critical life events that are significant in the current situation, and an increasing divorce rate could as well be observed during the pandemic. Pre-existing morbidities also play an important role, and existing symptoms increased. And there are higher prevalences for mental disease right now, and new reasons for anxieties emerge. And families with mentally ill children or parents suffer from the loss of social support and the absence of extra-familial activities. A few of the factors influencing mental health may be modifiable in the long term. As in the case of limited living space, there are fewer opportunities to stay outside the apartment or house during the pandemic. And there is a risk of financial loss or a loss of employment. So addressing the socioeconomic state. And it is also assumed that homeschooling will cause some students to be unable to keep up, and studying in general under the current conditions is associated with greater financial pressure. At the moment, healthcare workers in particular are suffering from an overload due to high workload and mental stress. And in addition, aiming at the services, there are higher prevalence rates of mental health issues, and they are met with a reduced offer of assistance. Some of the factors influencing mental health are modifiable to a certain extent, as vulnerability, and vulnerability is related to an uncertainty caused by conflicting information, because knowledge about COVID-19 is constantly updated, and furthermore, some people spread conspiracy theories that contradict scientific facts. But to the topic of vulnerability, it will be discussed in more detail in the second presentation. During the pandemic, the usual daily structure is interrupted, and home office, homeschooling, and childcare at home are all part of our everyday life right now. And social isolation is another important risk factor on developing mental health issues. It's clear that social distancing is unquestionably necessary to contain the pandemic, but it may lead to social isolation, which increases the risk of developing mental health issues. Alone living people are especially threatened by loneliness, and even if one's social network is well developed, it may offer less support at the actual situation. This also applies to stationary facilities where there are no opportunities for visits right now. The next topic is about emerging adults, and according to German law, this is a group of 18 to 26-year-olds. And this age group has specific age-related challenges to overcome, like the transition to working life, establishing a new home, and the search for a relationship. And during the pandemic, it's more difficult to get social support from people who share the same problems. And students are part of this group, and so they also have to overcome special problems during the pandemic, because university classes only take place online. And so a question that students often ask themselves at the moment is, should I move for my studies? Because many students struggle financially because they used to work in gastronomy, but the gastronomy is mostly closed right now due to safety measures. And starting a study in a distant place also means leaving friends and family behind. But at the current situation, there are fewer opportunities to meet new people. In general, the group of emerging adults has a high risk to develop mental conditions, and the pandemic influencing it in a worse way. To limit the negative impact of the pandemic on mental health, people must respond to it with resilience. And this is a dynamic process of positive adaptation in the presence of stressful events and difficulties. And if you are high resilient, it reduces the development of psychopathological symptoms after the exposure. And your development tasks can be mastered successfully. To be resilient means to have the ability to use flexible coping strategies in overcoming adversity, to recover from discomfort, and to have the ability to ask support when needed. And finally, we'll give a few recommendations on an individual level to limit the influence of certain of these factors. In order to counteract the lack of daily structure, it is advisable to get up at a fixed time, to plan physical activities, if inside or outside, to give space to your social contacts in different channels, communication channels right now, for example, via internet or phone. It is also advisable to take time for hobbies or to try new things or things that you want to do for a long time. It is also important to take meals at regular times. It could help you keeping a daily structure. And it's advisable to leave your apartment once a day to take a walk. To counteract the low access to service, it is advisable to use alternative communication channels with your existing social network, and to use your contacts to talk about your mental state, and to talk about how to deal with your lockdown, so you know how do your social contacts deal with the current situation. And if you want to start a therapy, it's important to ask several therapists for appointments. And if you have a long waiting time, it's important to inform yourself about online consultation hours or online support groups, if there are any offers. And it's also advisable to find out whether there are any exceptions to the assumption of costs by your health insurance. Yes, that's all, and I say thank you for your attention.
Well, thank you very much, Daniel, for this very thoughtful presentation and the recommendations for the students which are present. Now I hand over to Franziska, and we are looking forward to your talk, Franziska.
Yeah, a moment, please. Okay, can you see everything?
Yes, great.
Okay. Yeah, I will talk about vulnerable groups during the COVID-19 pandemic. And first, I will present the concept of vulnerability. In the second part of my presentation, I will talk about different vulnerable groups and about how vulnerability factors have developed during the pandemic. Afterwards, I will concentrate on...
It's a bit difficult to... the micro does not work well?
Maybe it's connection issues, I don't know. I will sit more close to the... Is it better now?
We can hear it well, Jutta.
Now it's perfect.
Okay, then I will continue. Yes, I will concentrate on the similarities of these vulnerable groups and on which strategies can help mitigating the impact of the pandemic. At first, vulnerability in general describes the genetic and/or biographically acquired susceptibility of a person or a group to diseases and problematic behavior, or the disposition to develop addictive behavior or a mental illness, which means that vulnerable people are disproportionately exposed to risk, and who is included in vulnerable groups can change and depends on external influences, like in this case and at this time, the influence of the COVID-19 pandemic. The first vulnerable group are healthcare workers, because due to the spreading of COVID, capacities of hospitals and intensive care units had to be exceeded, which changed the setting for healthcare workers, leading to higher pressure. And having to make triage decisions and witnessing increased mortality of patients while working under maybe insufficient personal protection measures also contributes to the higher pressure. In addition, healthcare workers are at high risk of getting infected with COVID and often suffer from social isolation because they fear transmitting COVID to family members or social contacts. Our next vulnerable group are migrants. They often live in precarious housing conditions, which on the one hand leads to a higher risk of infection, for example, in refugee camps or other living facilities. And on the other hand, limited living space leads to a higher risk of exposure to abuse during the pandemic. Also, migration is often related to a lower socioeconomic status, and the pandemic situation can cause a loss of employment, an even more unstable employment status, and therefore severe financial problems. Also, the increased demand for healthcare caused by the COVID situation can make it hard to access to healthcare, which is problematic because many migrants suffer from pre-existing mobilities like mental health disorders due to traumatic life events. And during the pandemic, integration can be hindered, and therefore there is a higher risk of experiencing structural stigmatization and social exclusion, while language barriers make it harder to access to information or helping facilities, and for example, in cases of abuse. The next vulnerable group are people with substance use disorders, because due to pre-existing morbidities, they are more likely to suffer from increased symptoms or newly developed mental diseases, which goes hand in hand with an increase of substance use and a higher risk of death due to overdosing. Because of social circumstances and an already affected immune system, there is also a high risk of getting infected with COVID and also dying from the infection. And another risk factor is the danger of social isolation and stigmatization, especially because of a disrupted access to peer support groups and the possibility of gathering in public space and the consequent loss of social contacts. Also, during the pandemic, access to helping facilities like emergency accommodations is often limited or disrupted, which leads to a higher risk of homelessness. And the last point is that the overwhelmed healthcare system makes it harder to access to required treatment or medication or therapy, which is a really high health risk. We interviewed residents of an addiction treatment facility and found out that their most perceived burdens were social isolations due to the safety measures and the increased distance to others, as well as the interruptions of daily activities and daily routines like sports or trips, and in general, the lack of control over what is happening due to the situation. And this affected their mental health. They noticed mood swings, feelings of arousal, anger, and anxiety, and in general, difficulties in controlling and regulating their emotions. Their own personal strategies for the situation are trying to maintain social contacts and to distract themselves with activities in a way that is still possible, and overall a known positive and active coping behavior. So now, after concentrating on the factors increasing vulnerability of particular groups during the pandemic, what do they have in common? This survey done by the Canadian Mental Health Association shows that since the outbreak of COVID-19, 6% of the general population have had suicidal thoughts, while the same goes for 18% of people who were already struggling with their mental health. And other minorities like people with disabilities, low incomes, or indigenous people have a similarly high percentage, especially in comparison to the general population, which shows that for groups and minorities with pre-existing health issues or financial issues, or in general people rather on the edge of society, it is even harder to tackle the burdens and changes caused by the pandemic, and that it exposes them to a really high risk. The pandemic and the required safety measures can cause feelings of loneliness, hopelessness, and despair, paired with a higher risk of being exposed to stigma, prejudices, and marginalization. And as this study done by the UK Mental Health Foundation shows, at the beginning of the second wave in April 20, almost 75% of people were coping well or fairly well with the stress related to the pandemic, while that number has decreased to approximately 62 to 64% until the 9th wave in December, which also shows that throughout the process of the pandemic, the population's emotions have changed. And right now we observe a reduced ability of emotional control and a rise of, for example, feelings of anger. And also there is very limited access to services and facilities which are highly required by vulnerable groups for meeting their special needs, which is also related to the shifting emotions and the problems. We as a society need strategies for meeting these needs, especially during the pandemic, for mitigating the impact and the risk put on vulnerable groups. And there definitely should be extended and improved access to therapy or assistance offers, especially online. And we need to inform vulnerable groups in a new adequate way, like, for example, via social media, employers, doctors' offices, or schools. And we also need improved safety measures in stationary facilities and healthcare working spaces to minimize the risk of infection and also the fears of vulnerable groups. And in general, we need much more, much more awareness has to be risen for mental health and consequences of stress and how they are affected by vulnerability factors, especially during this pandemic. And in this difficult situation, it is absolutely necessary identifying and supporting the needs of vulnerable groups, because we see the risks more than ever right now. And society has definitely to improve its strategies for meeting them. That was my presentation, and I also thank you for your attention.
Well, thank you, Franziska, for this very diligent and thoughtful presentation. So, by both presentations, we have got an excellent overview on the state of knowledge, on what is known at the moment, and specifically what we saw is that mental conditions change over the course of the pandemic, which means that there is a real need for longitudinal approaches to better understand the real multidimensional changing impact. So I'm looking for questions to both presenters. And at the moment, I do not see any questions in the chat. So please, in case of questions, comments to the presenters, write it into the chat or unmute your mic. Both is possible. Otherwise, maybe we can reflect a little bit about this concept of vulnerability. So, how would you define vulnerability in the context of the pandemic? And maybe what can we learn for further investigating vulnerable groups? In case this is too much, maybe this is something we can discuss in the whole group. How can we proceed with this concept of vulnerability? Franziska, do you have maybe any answer or preliminary answer for the concept of vulnerability?
I think that especially right now during the pandemic and also the very dynamic situation, it is very important to react in an adequate way and to get like the new requirements of especially of vulnerable groups in a very fast way, because I think the situation can get out of control easily, and we have to have strategies for that, for not putting the vulnerable groups to a higher risk than needed.
This is a very thoughtful answer, which means there might be groups which are vulnerable before the pandemic, and then quickly it's changing. So vulnerability is mainly a concept of interaction. This is some maybe some food for thoughts in the future. Thank you very much. Are there any further questions? Specifically, maybe to the interruption of services and to the interruption of services for students. We heard from the students in Lithuania that they were quite satisfied with the help from the university. So my question would be to the group of German students, whether you have a need for support, or what did you observe in the other students? Maybe a question to Daniel or to the group behind Daniel. This quick new situation. The colleague from Vilnius said that there were like measures and he felt very well, even in the situation of the pandemic. So basically, I heard that it wasn't too bad to move to the online teaching. So my question would be maybe as well to the Belgian students, how did you feel with the new situation? What did it mean to you? Difficult question? Maybe because it's difficult to answer, because from studies now we know that for some students it was like an advantage to be able to study from home, to save time, and for others it was more a challenge. So really we need more studies, we need more data, and because the aim of this section, this workshop today, is to build bridges between countries, to build bridges between disciplines, and to build bridges between sectors. Now it's my great pleasure to introduce to you a project which is specifically targeted at improving data, at improving the data we have. And therefore I would like to ask Carmen Rodriguez Vázquez and Martin that they share their screen. Carmen is from the Spanish Public Health Institute and Martin from the Robert Koch Institute, which is similar to the German Public Health Institute, and they are sharing their first thoughts and their plans to a new joint action on population health information infrastructure. So I think, Martin, you are the first to present. Maybe you would like to share your screen.
Thank you so much, Jutta. I hope you can hear me.
Yeah, perfect.
Great. Yeah, thank you very much, Jutta, for the possibility to present to you today the Population Health Information Research Infrastructure for COVID-19 and its use case on the impact of COVID-19 on mental health. As you said, my name is Martin Thyssen. I'm working for the Robert Koch Institute in Germany for the Department for Epidemiology and Health Monitoring. And I will start and give a brief overview of the FIRA project, that you know a bit more about the background, what the aims are. And afterwards, Carmen from Instituto de Salud Carlos III in Spain will take over and present the use case on mental health. Okay, next slide, please, Carmen. Great, thanks. FIRA, it's called FIRA, Population Health Information Research Infrastructure. Started in November 2020 and is a project funded by the European Union's Horizon 2020 program. And in FIRA covers a lot of different partners. It covers 41 partners in 30 different countries. So as you might imagine, the exchange and the conversations are quite complicated and complex, but it's very helpful to be better in some technical issues regarding communication channels, online meetings, and all these things. They're much simplifying our work these days. Included are national institutes like public health institutes or university, and of course ministries of health and research. And the project in general consists of 9 different work packages. We are not touching the ground on that, but just that you know. Next slide, please. What are we aiming for? FIRE aims to identify, access, assess, and reuse population health, but not just that, also non-health data that is influencing health. And we are often looking at the infectious side of COVID-19, for example, but there are also the indirect or wider effects of COVID-19, for example, on mental health. And this is the aim. We are watching at these non-health data in European member states and across member states to generate the best COVID-19 population health knowledge to, in the end, underpin decision-making, political decision-making, providing data as the basis for decision-making. Furthermore, it will allow a better coordinated European effort across national and European stakeholders. So we involve in the project, for example, the ECDC, Eurostat, the GRC, which is a joint research center of the European Commission, the OECD, and the WHO. Within this FIRE project, we do have a work package that deals with the research and research use cases. And this is the work package we are going to take a look inside today. The research use cases measuring the impact of COVID-19 through 4 different use cases of immediate relevance. We want to demonstrate how a broad variety of secondary data, administrative, survey data, and so on, can be pooled and reused in a distributed way across Europe and the member states. Our goals are on the one hand, to conduct research through the use cases on the consequences of COVID-19 pandemic, to provide information for politicians and decision makers, but on the other hand, next to the research part, these are pilot activities for the benefits and added value, and that is our goal of a research infrastructure by bringing together data from different countries and feed them into a federated research infrastructure. What that is, I will show you on the next slide. These are the four use cases, include direct and indirect effects of COVID-19 and vulnerable groups. That's the first one. COVID-19 related delayed care in breast cancer patients. That's the second use case we're looking in. The impact on perinatal and perinatal health that is carried out by the EuroPeristat network. That's a European perinatal health network that is already existing. And the last one, and this is the focus today, the COVID-19 related changes in mental health. All these outcomes of the use cases will feed in an interoperable way. That's very important, that data is interoperable into a federated research infrastructure. How does this work? Just briefly, a number of different data holding institutions within Europe declared their interest to share their data regarding these 4 use cases with us. These institutions host or curate data or have easy access to the data and contribute them. These are so-called data hubs. Carmen will say data hubs a lot of times later on, so that just that you know what data hubs are. And we don't have any problems in this federated research infrastructure with privacy or data protection, because the data hubs, the data contributing countries or institutions, do not share any data across the infrastructure, because they are just scripts that move and models that move, and in the end, aggregated anonymized outputs that will be moved. So no individual or aggregated data from the countries will move across countries is just scripts, models, and aggregated outputs. So, and these outputs will be made available in a health information portal that will be launched on the 31st of May, not with the outcomes of this project because it has already started right now and we need a bit more time. But from the project before, it's called Information for Action, and some best practices, health information tools, some training materials on burden of disease, and so on and so forth. It will be made available on the 31st of May in the health information portal. It's www.healthinformationportal.eu, and that's it with the commercial break. So that's it from my side, and I love to give the floor to Carmen touching the ground on the use case on mental health. Thank you very much.
Thank you, Robert. Good afternoon, everyone. As Robert said, I'm going to talk you a bit on what we are going to do on this use case on COVID-19 related changes in population mental health. The first action we did was to complete a questionnaire. Each data hub completed a questionnaire to have some characteristics on the data they manage, they curate, or they have access to, and the data hub's capabilities. These are the participating countries and institutions in this first questionnaire. As you can see, there's a lot of participating countries. And these are several results from this questionnaire. Most of the institutions did host health or healthcare data, most than 80% of them. Moreover, most institutions were also capable of accessing health or healthcare data from external institutions. All of them had health or healthcare data at an individual level. And also nearly 90% of them have the data available at an aggregated level. Regarding the COVID-19 related changes in population mental health, what we are going to see is how the COVID-19, the disease per se, or the confinement measures, the preventive measures, have impacted in the mental health of the population. So the objective of this research, this use case, is to study how this pandemic has changed the population mental health. We have defined a research question. That is a question we are going to answer with the data we are collecting, or we are asking the data hubs to analyze. Our research question is, has the mental health status understood as depression or anxiety of the general population changed during the COVID-19 pandemic? We will use two sources of data: registered data with indicators such as prescription of antidepressants, anxiolytics, visits to primary care, specialized care, of patients with an episode of depression and anxiety. But we also want to have a look at survey data. During the pandemic, a lot of different surveys has been carried out in most countries. And we were going to have a look at indicators of depression and anxiety in these surveys using validated rating scales of self-reported depression and anxiety. For each indicator will be request the name of the variable, groups or categories that we can the data have, the level, if they are national, regional, individual, and very important, if the data can be linked to infection, hospitalization, mortality, or even vaccination data. With all these indicators, we will do a data scheme with the data needs and the 16 data sources, and to perform a common data model. This is an example of the data scheme for this use case of mental health. We will have all the variables we are interested in, the visits, the sex, the age of the patient. So we are going to codify, to encode the variables according to, for instance, the ICD-10 or the APC or the ICPC systems. And the next step with this data, and with the data hubs, we will make a second run survey specific for each use case to start off the process of harmonizing data throughout the common data model. With all this information, we will create models and we will analyze the data to answer our research question. And this is what we wanted to tell you. And thanks for your attention. Thanks, Jutta and Yufa, for giving us the opportunity to present this joint action. And we would like to present our website and our Twitter account if you want to receive more information on this project. Thank you very much.
Thank you very much, Martin and Carmen, for this insight into the exciting project. Maybe we have any questions from the audience about it. It's a huge project, very ambitious. So maybe there are any questions. So in case not, maybe I can ask a question. How will you identify all these enormous amounts of surveys which are going on in each country, all these cross-sectional and longitudinal studies? Nobody is aware of what is going on. So how will you identify all these studies to get a comprehensive overview? Do you have a strategy for that? Maybe Yufa, maybe we can contribute to it.
Yes, each country will contribute with their own surveys or register data. So each participating country will decide which kind of data they want to use for the model. All this available data to always think that we have to answer a research question. So they are going to select and to contribute with the data most adequate for answering this research question.
Yeah, maybe I can add to that. We also have a work package within this project dealing with exactly what you said, Jutta. What is happening within the European member states? What are they doing? It's not just literature review, what is available on COVID-19 and the wider effects of COVID-19 on population health. It's also on these specific topics like mental health, cancer care, and all these things. There is also research and reviews ongoing that provide us the information in our work package, what is happening within these countries, which data sources are available. And in the end, as Carmen said, the data contributing institutions are responsible for providing and contributing data, the surveys, what the register data they have in their countries. They have to figure it out in their own countries and then contribute it to the whole group.
Thank you very much. Maybe there are questions from the students about this project.
Yes, I've got a question. Thank you very much for your nice presentation. My question is, maybe I just didn't understand the project completely, or however, how will you make sure that the collection of surveys and well, there will be a huge variety of very different approaches. How will you make them comparable and make sure that they are all authentic and will work properly, and that there are no flaws, and weigh them, because some may have greater statistical value than others? How will you take care of?
Well, a very good question, Jacob, because we are really dealing with the quality of COVID surveys at the moment, and it's a matter of representativeness of the data. And what we found out, at least from the public mental health section, together with Maria and Johan, is that we are in real need of comparable European data, because we can learn much more by comparing data across Europe, and if it's possible, even beyond Europe, because one country alone, at least to the best of my understanding, cannot really disentangle the different factors which might contribute to mental conditions.
Yes, answering Jacob's question, this is what we are doing the data schema for. For this, using this data schema, what we are doing is to harmonize, to select the information we really need to answer the question. And we have a consensus between all partners that these are the variables we need to answer this question. If the data come from a register or from another, it's independent on the variables we are using with this data schema.
Exactly. That's exactly the point. And we are, the countries itself, preparing their data according to the data schema that the use case leads, in this case, Carmen, is providing. They need these variables, this and this and that, so they exactly know how to harmonize the data they have. We are quite agnostic which data source it is, but if we choose survey data now, and we are not looking in the quality and how they evolved or something, or how the survey was conducted, we are just looking at the data they are providing us, and they have to adapt their data to our data schema, and then we will centrally, in a central hub, which is the IX, the Health Science Institute also in Spain, will provide the countries with scripts for their analytical pipeline. So we provide the data schema. The countries will take a look at it and prepare their data with regards to that and see if they can contribute, if they have the data available. Then we will provide them with the scripts and the analytical pipeline. We harmonize it in a technical way. So in R, for example, that they can all use it. And then they are running the analytical pipeline with their survey data. So, and in the end, we get aggregated outputs from the countries and put them all together and provide them on the health information portal. So that's the way, in an abstract explanation, it's very complex to explain it in detail.
Okay, thank you so much. Thank you very much. Now I would like to call Johan and Maria on the stage, let's say. We have some more minutes to discuss all the presentations which we heard today, which gave us a huge and really good overview about some research projects, about the knowledge students have, about what is going on at the moment. So again, I would like to ask students and attendees of our session whether you have any comments, any questions, and I think Johann and Maria and I will be happy to answer this question in case we can. So I don't see any questions, any comments. So maybe then I will try to try something. I don't know whether it works with the internet connection. I would like to call the presenters from Lithuania, to switch on the video, and the presenters from Lithuania and the presenters from Germany. Would you mind switching on your video?
I'm from Belgium.
For Belgium, sorry. Okay, because then it's a bit easier maybe to come into contact with each other. Normally what we do at the summer school of the public mental health section is to learn together, to ask questions, and to move forward in the field of public mental health, which is much easier if we meet each other. But now let us try at least to establish some connections and maybe questions you students have to other students. Because the aim of our workshop indeed was to establish connections, to build bridges. Maybe Johann has a question to the students. No, it's professor's time. We can ask what we want.
I have many questions to the students. No, I would like to know whether or not students have an expectation to an organization like the Public Mental Health from the European Public Health Association, what we can do or how we can organize some sessions or meetings which would be interesting for you as students. We did already summer schools in Vilnius, I think it was always in Vilnius, but perhaps we can also do it in other countries. Do you have ideas about what is interesting for you as students to have a conversation with other students about what theme, about what subjects, how would you organize it? What would you suggest to us? You can help us to make something interesting of it for the future, perhaps.
Then, by the way, the next summer school in 2022, at least at the moment, it's planned to be held in Porto, Portugal. So it will be a good opportunity to meet again, to meet hopefully in person, and maybe there are some ideas what might be a topic which is specifically close to your heart.
Yeah, and related to mental health.
Sure.
Yeah, so maybe I can start with answering the question. For us, during our work, as we did a survey among European students, it would have been very, very nice to have a comprehensive network of maybe universities or institutions to spread such a survey to reach people in order to increase the sample size and to increase the diversity of the sample size. Because I think all of us agree that this research among students is important either as a portal to enter research working, And maybe the outcome is also interesting. That's then the second point. But to have a comprehensive network of students would be very good in order to spread such a survey. Of course, it shouldn't be overused, but it would be good to have some people supporting contacted students in different countries.
Excellent idea. So maybe our session can be the start of such a network. And Johann and Maria, we will discuss how we can disseminate your email addresses legally so that you allow us to share these addresses, and then you can start, and we can start to build up such a network. Sounds like a pretty good idea.
Maybe it is possible to have a person at UFA, for example, where we can where any student who wants to create such a survey can contact and show their work, and the person says, oh yeah, this is really good, and then here I have a contact for you there and there, or the person can also say, maybe you committed a little more work, and then so it's not publicly open all the time, but you go to UFA and say, hi, I have this, what you think, and can I go for it? And in order, like this as a first step to gain a broader audience. Just an idea.
Well, let us think about it, because of course all these studies need quality standards, and so there are a lot of hurdles so that it can be done. But let us think about it. At least I think it's a very good idea to establish such kind of a network.
I also would like to support Jacob's idea, and I see also the comment in our questions and answers section that for young researchers that at the just primary steps, the networking and finding the similar thinkers and collaborators, maybe for students it would be an absolutely added value, because that would enable them to do some comparative work and support them in their both learning and doing process. So thank you, Jacob, for the idea. And indeed, we will think how we could support young researchers more specifically in public mental health field.
Any further comments? You can write into the chat. You can switch on your video. We all know that sometimes the connection is a bit difficult.
I have also another question. Do you have, as students, do you have some time left to do something else than studying? I mean, to make contact with other people from other countries, other students, or do you say, no, I have no time, I have to study exams, and that's my main task, and please don't bother me with other things? It's only a question.
I think there are a lot of social media in which students can have contact with others. Now, I have to say personally, I do not have contact with a lot of other European people of my age, but I think there are a lot of how should I say, possibilities to get in contact with others. But yeah, for me it is not. I'm still here in Brussels, fine with my. I'm trying to keep go in contact with my students from Brussels here. That's more than enough.
May I ask a question also to all the students from Germany, from Belgium and Lithuania? How did you come up with your research ideas?
Can you repeat the last word, Maria?
How did you come up with your research ideas for your projects and presentations?
Mm-hmm.
Was it like something, a reflection from reality, or professors stimulated to focus on that? Or how did you find those topics so interesting for you that you dedicated your time and efforts to work on it?
I think for us, it was so that we got a topic, a main topic, and then we could choose a more specific topic to focus on. So for our research, it was online learning in these times of COVID-19. And we thought it was interesting to search some difference in experiences by students for the exams. Because for us as first-year students, we also have our first exams this year at university in COVID-19 times. So we thought it was interesting to see a little difference in exams in normal times and on write exams now, because we don't know any other situation than right now, our exams in this kind of weird time. So we thought that was a little interesting for our research.
For us, it started off as a, oh, sorry.
No, go ahead, Jacob.
For us, it started as a stupid idea with a lot of beer. We had the option we have a public health project in our third semester, where we either have to write a literature review or do a little survey. And I think the minimum participants were like 20 or something. And we thought, okay, we don't want to read so much, so we do a survey. And then we started off with some friends. And at some point, Paul and I were like, oh, this is really low. We can do better than this. And then we started to spread it out and started to see, oh, this is interesting. People are interested. So we increased it further and further and got a lot of positive feedback. So we basically stumbled into it, not planning what we were doing.
This is an interesting explanation. This is some perhaps a message to the people from the National Institutes of Public Health. If people don't want to read, they start doing a survey. So this is very nice. So thank you very much for all these valuable contributions. Thank you for your great talks, really well prepared, all the talks. And for the lively discussion, I would like to remind you that the European Public Health Week still continues until Friday with more than 200 events organized by 40 countries in 19 languages. And still is Public Mental Health Day, and there are other events. Check it out, what is going on at the moment. For example, at the moment, there is an event organized by Porto University about students' mental health. And there is a very good survey done in a longitudinal one in Porto about the effects of COVID on students' mental health. So it will be nice for you maybe to connect and maybe to listen what they found out, because it is a bit different. And therefore it is so interesting to compare and to bring together the national data which we have. Herewith, I would like to conclude and thank you again, everybody. Thank you to the discussants and thank you to Martin and Carmen for their time and for their contributions. And I'm sure Maria and Johan have some words to say as well.
Unmute. No, I also want to thank you all to participate. And I think whether perhaps you don't see it now at this moment, but I think in the future it can be a nice cooperation to have more like events like this to bring together students from different countries, because it's enriching. in some way if we have more talk, because now it's very short, but if you have more time to learn, to know each other, I think it can be very fruitful and interesting. But so also from my side, thank you very much for all the participants, and I hope to see you back somewhere. From some, I'm sure I will see back, but I don't know. Bye-bye.
I just could add another thank you, especially to students who made presentations and broke ice, probably some of you for the first time. So our deepest thanks for your courage, and yeah, all the best, and be resilient in these COVID times, and all the best with your exams.